Good afternoon. Welcome to UCSF Department of Medicine Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. Before we get to today's topic, it seems important to take note of the Supreme Court decision this morning. For many, many years, we have been working very hard to diversify our training programs and our faculty, and there's no question that our successes in doing so have made us much stronger as a department and as a university. We will be waiting to hear legal guidance from the campus and from the Office of the President, but we will continue to do what we can legally to continue to promote a diverse department. We'll talk a little bit more about that as we get started. Turning to today's session, a quick program note. This will be the last of our grand rounds during this academic year. We will resume right after Labor Day. So if you've been holding every Thursday at noon, and I hope you have, you can do other things for a few months until we get started again in September. Today's Grand Rounds also marks a special, I think, turning point in the COVID pandemic. We launched COVID Grand Rounds, I think on March 18th or 19th, 2020. I just decided to repurpose this forum to become a COVID forum, and it was every single Grand Rounds for, I think, about a year. And then we dialed back its frequency, and now we've been going at it for once a month doing a COVID-related session. Over the past 3 years, we've hosted more than 50 COVID sessions featuring more than 100 local and national leaders. You'll meet 3 national leaders today. We've had tens of thousands of live viewers and close to 4 million views on YouTube. And I think the feedback I've gotten from all of this has been immensely positive, and it's been quite gratifying. For our last Medical Grand Rounds of the academic year, it seemed appropriate to have this be the final COVID-specific Grand Rounds. When we get started again in September, we will certainly cover COVID-related topics as new developments arise, and it seems appropriate as we do other important medical topics. For the session, we brought back 3 of our favorite experts to discuss what we've learned over the past 3 or 4 years in a wide variety of areas. And the discussion, I'm sure, will go all over the place, and the challenge will be getting it all in 55 minutes, but we'll do our best. The speakers today are Carlos Del Rio. Carlos is Professor of Medicine in the Division of Infectious Diseases, and he's also Interim Dean at the Emory University School of Medicine, as well as Interim Chief Academic Officer at Emory Health. He's also, if that wasn't busy enough, he's also currently the president of the 12,000-member Infectious Disease Society of America, the preeminent professional society for infectious disease practitioners. Carlos, welcome. Next up will be Caitlin Jedalina. Caitlin is an epidemiologist, data scientist, and internationally renowned scientific communicator. She has been a senior advisor to a number of government and nonprofit organizations, including the White House and the CDC. If you don't follow your local epidemiologist, you need to. It's a public health newsletter that translates ever-evolving science to the public. It's been viewed over 300 million times. I think I'm responsible for about 100 million of those. It's been an absolute go-to resource for all of us that have been following COVID and other interesting and important epidemiologic issues. Caitlin's received a number of awards for her work, including from the National Academy of Sciences and from the Department of Health and Human Services. Caitlin, welcome. Thanks for joining us. And last but not least, our old friend Mark Smith. Mark is clinical professor of medicine at UCSF in our HIV, ID, and Global Medicine Division at San Francisco General. Mark, who was a resident with me back in the day, went on to become founding president and chief executive officer of the California Healthcare Foundation. He was elected to the National Academy of Medicine in 2001 and chaired the Committee on the Learning Healthcare System, which produced the 2012 report, Best Care at Lower Cost, tremendously influential. Mark serves on the board of directors of several companies of foundations, including Teladoc and the Commonwealth Fund. And I'm pleased and proud to say he continues to practice clinically in the HIV practice at the county. So Mark, welcome. Let's go ahead and start. Let's say a word about the Supreme Court decision. I think both Mark and Carlos wanted to say a word. Mark, why don't we start with you?
Well, as a graduate of both Harvard and the University of North Carolina, and as a beneficiary in some ways of the change of attitudes that underlay affirmative action, I think it's a terrible decision. But I'm actually confident that, unfortunately, it doesn't come as a surprise. And I'm confident that Emory and Harvard and UNC and UCSF are already at work in trying to figure out how they can stay within the bounds of the law and still respect the need to create greater diversity for the benefit both of students of all races and backgrounds and of the institution. So not happy about it, but not heartbroken either, in part because I was expecting it.
And thanks, Mark. Carlos?
Yeah, I agree with Mark. This is something that many of us were expecting. But at the same time, I know that many of us are committed to diversity, are committed to improving diversity in our profession. We have, as a Hispanic male, the number of Hispanic physicians is incredibly low. That population is increasing. We know the number of African-American physicians, primarily, male African-American physicians, is low. So if it's not race that we use as a criteria for admission, it has to be, improving the diversity of our providers, so we can actually improve health of our population. There's plenty of data that one of the best ways to improve outcomes in African Americans is to have an African American physician. The same can be said about Hispanics. So we care about the populations we serve. We have to continue diversifying and living by our principles of diversity, equity, inclusion. So I am there, and we'll do it within the law.
Great. Thank you both. I appreciate that. Let's move over to COVID. I'll turn to Caitlin. Maybe could you describe how you see the current state of COVID? Is it over, not over, back to normal? And maybe also how you are acting in your day-to-day life.
Yeah, I think that's a billion-dollar question that we don't really know where we're at right now. I think we're in this really weird transition phase between full-blown emergency and not yet endemic yet, not yet predictable yet. Right now, today, SARS-CoV-2 is mutating twice as fast as the flu, which to me signals that we're going to have more waves. I think we're all really holding our breath to see how the rest of the year plays out. If this has already become seasonal, or if we're going to just have 2, 3, 4 waves a year, no one really knows. The other thing we're all kind of holding our breath on too is to see if this continues to have the ladder-like mutations of Omicron, or if we're just going to get a random mutation out of the blue. And really discussing and debating what the probability of that is. I think the probability of this random variant of concern coming up is between 20 and 40% within the next year. So there's a pretty good chance that it may happen. Right now, today, transmission is incredibly low. And I think that it is a welcome reprieve for a lot of us. And so personally, as a young, very healthy individual, I'm not doing much. I do wear a mask at the airport because I just don't want to get sick because I'm traveling all the time too. But other than that, and keeping up with my vaccines, there's not much going on in the Jetelina household.
So let me ask a couple of follow-ups. So at the airport, but not the airplane?
That's right, actually. So I'm wearing it the boarding area through security. When wheels are up, I take it off to have a drink, have some food, and then wheels down, I put it back on. And the reason for that is, one, really low community transmission right now of COVID, but also RSV and flu. I mean, it's very, very low. Mm-hmm. And because of the ventilation systems within the planes too. Okay.
And you said it's not predictable and we could have another surge. I mean, it sort of feels like since January 2022, I guess, with the last big COVID surge, to me, the most surprising thing has been the absence of surprises after 2 years of one curveball after another. So it's obviously anything could happen and we could have another pandemic from a different virus completely. It does feel sort of stable, doesn't it, to you?
It does to me too. I don't want to jinx it though.
Oh, you're not jinxing. I don't think, did you learn, in your PhD, is jinxing it is like part of the, part of what you learned?
No, it's not. The one thing I learned, I mean, if we start talking about lessons learned, is to approach this virus with a level of humility. Mm-hmm. That it gave us a lot of surprises, and that is something, and we continue to learn about it. And so mm-hmm. I am not a betting person, and really approaching COVID right now cautiously optimistic.
Got it. Carlos, how about you? How are you seeing the current moment, and how are you behaving?
I'm a little more optimistic, Bob, and I would say that COVID in June of 2023 is not COVID in March of 2020. We don't have. I mean, all of us that worked in hospitals saw people coming in, saw our ICUs fill, so people very, very sick. I remember patients, coming in being, with respiratory distress in the morning and dead in the evening. And the most important thing that has changed is that now we have an immunity barrier, right? Immunity wall between vaccines and prior infection, and a combination of infection and vaccines. We have an immunity wall that is pretty significant. And I think, COVID has mutated, but so far the vaccines continue to protect you against severe disease and death. And therefore the outcomes that really matter, severe disease and death, have gone away if you're vaccinated, and you'll get infected and you're going to get sick for some days. But, I've had the flu a couple of times, and that's no joke either, right? It's still a pretty bad disease. So the reality is I'm pretty optimistic. I think that where we are right now is in a much better place than where we were 3 years ago, and we need to be happy about that. And the reality is the people that we're still seeing getting sick and getting in the hospital and dying are people over the age of 65, primarily over the age of 80, who have not been boosted. So the part that makes me uncomfortable is what percentage of the U.S. population has not received their third booster, let alone a fourth booster. Mm-hmm. But, we only have about 16% of the U.S. population that has received a third booster. We only have about 40% of those over the age of 65 that have received a third booster. That's my concern. As somebody who's, 63, almost 64, and full with my vaccines and has had COVID once, I feel pretty good about my hybrid immunity, and I'm pretty comfortable doing a fairly normal life nowadays.
So are there any circumstances where you wear a mask?
As Caitlin said, when there's lots of people in crowded spaces with bad ventilation, I still get a little uncomfortable, and I don't like it. And I either wear a mask or stay away from a lot of people. I don't like to be, and that may be, if I'm inside a metro car, for example, and it's full of people, I get uncomfortable, right? But the reality is that, I'm going to restaurants, I'm dining inside, I'm traveling a lot, like Caitlin said, and this 2 weeks ago, I got a cold after traveling, and I don't know what it was, but it wasn't COVID. Mm-hmm. And it's going to be part of life. And yes, I'm really trying to be as normal as I can, just because at the end of the day, I like socializing, I like seeing people, I like going out, and I think we need to get back to a more normal way of living than when this isolation, that separation that we had for a long time, is not good for the mental health of anybody.
Mm-hmm. Thanks. Mark, how about you?
Same. I wear a mask when I'm in a closed car with somebody I don't know and whose status I don't know. We've been debating whether or not the table that's been by the door since March of 2020 with masks and tests and booties and hand sanitizer, whether it's time for it to come down. My wife says no, so it's still there. But yeah, I'm the same place everybody else. But you know what I mean? It's also important to remember, as we emerge from this, we all remember the days that there were refrigerated trucks in the parking lots of these hospitals. And when people were desperate to try to figure out, do steroids work? Do they not work? Do you pronate? Do you not? And we shouldn't, in our zeal to get back to normality, we shouldn't forget that, because there's a kind of revisionism now that says, oh, well, we overreacted, it's all okay. 1 million people, it was not okay. It was not okay. And we don't know what the next one is, as Caitlin said. One more thing. I want to thank, on behalf of all the thousands of people who will watch this, you, Bob, and you, Caitlin, for being among the most important voices that could help both professionals and lay people get a handle on this thing as it became polarized and as people speculated randomly. So I think we all owe you a debt in terms of your ability to communicate in real time, admitting uncertainty where we had it, and there was a lot of it. It's been a very important function, I think.
Thank you. That's very nice of you. Before we get to the revisionism, because I want to do peel back, and because I do think there's a lot of it now, just ask maybe Caitlin about boosters. Are you getting one in the fall? Did you get one in the spring? How are you feeling about more shots?
So I did get the bivalent in the fall. I didn't get one in the spring. I wasn't eligible for one.
It's
And
like
this,
the ninth time you've told us how much younger you are than the rest of us. I just,
Yeah,
just,
thanks a lot,
just want to
Caitlin.
point that out, but go ahead.
Yeah, right. Go ahead.
uh, it's just a different reality, right? Like Carlos said, there's just different risks to different people. But so yeah, I got it in fall. I don't know. I think it'll be really interesting to see what happens this fall with recommendations. We don't know who's going to get the recommendation for a fall booster. I've heard whispers that it's going to be for everyone, like we treat the flu, but I could also see it going the other way where it's for over 65 because of their weaker immune system. So if it's recommended for me, absolutely, I'll get it.
So you'll
but-
continue to get a yearly shot if that's the recommendation
Sure.
for everybody. It sounds like you don't see much downside.
Not for me, no, not at all.
Yeah. Okay. And are you factoring long COVID into your decision making, both about your level of caution with masks and gatherings, and also with your decision making about boosters?
I struggle with long COVID a lot and the risks and where to place long COVID in my repertoire of risks. And so, yeah, I guess so. I mean, at some point, I mean, I don't want to get infected. It's not inhibiting me from living life and going to a bar or a concert, but it's certainly not something I want to gamble with. And I've had a lot of friends that are like on heart failure medication that are my age for the rest of their life because of long COVID. And so I don't know, I struggle with it. So I guess my answer is yes, but it's not dictating my life.
So it sounds like at the margin, if it's a close call, the idea that if you get COVID, you're certainly not going to get super sick with your vaccine status and yes, your age. But long COVID does cross your mind as almost a tiebreaker. Is that a fair interpretation of where you are?
Yeah, I think that's fair.
Okay. Carlos, how about you?
Yeah, I totally agree with Caitlin. I think I also got a booster in the fall. I did not get a booster in the spring since I'm not over 65 yet. But when there's a new booster coming, and my hearing as Caitlin is that it will be probably recommended for everybody, but definitely should be, strongly encouraged for everybody and recommended for over 65. I'll be 64. I'll take one. I think that it will be the right thing to do. I love vaccines. I think they're great, and I think vaccines have really made a big difference, and we cannot ignore it. Long COVID, it's in my view, and is the thing that I worry about. I worry because I see patients with long COVID, and I worry because I'm interested in the pathogenesis and the disease. But I also know, Bob, that if I get infected and I start therapy right away, my risk of long COVID goes down. So I keep plenty of rapid tests at home, and I'll, as I said, I travel and I get tested really frequently after I travel. I'm obsessive about getting tested, and I started having symptoms. After my last trip, I tested, and it was all negative, so it wasn't COVID, including a PCR. But had I tested positive, I would have started Paxlovid right away, and I would have decreased my risk by doing that. So I think we need to have a rapid entry to diagnosis and therapy as part of our approach, and that's my approach to long COVID. I want to go back to what Mark says, because I want to emphasize that to people. Yes, we cannot be revisionists, right? This was very serious, and this killed, over 1 million Americans. And I tell people that if we had been in this same Grand Rounds, Bob, in April or May of 2020, and we had said how many Americans are going to die. I remember talking to Tony Fauci about this, and he said, maybe 60, 80,000. If somebody had said over 1 million, I think we would have been called crazy, right?
Yep.
We would have said there's no way that will happen. So when we go about lessons learned, I think one of our lessons learned, and one that I worry that keeps me up at night all the time, is our healthcare system was grossly unprepared for this. And our healthcare system continues to be grossly unprepared for this. Mm-hmm. So I don't care if it's COVID or if it's any other pandemic, our healthcare system is working still at the edges and working at the margins. And it seems like we didn't learn the most important lesson, is that our healthcare system is simply not prepared for a pandemic.
So you think we're better prepared now for the next one? It feels like at least
not our health. I don't think our health. I don't think our health systems. I don't think the healthcare systems are prepared.
So what do you mean? Make that specific. What should we have done or be doing that we haven't done?
Well, our surge capacity is essentially zero. I don't know how your hospitals are over there, but we're at full capacity. We have people waiting in the emergency room, 20, 30 people waiting for beds in our emergency rooms regularly. So getting a bed is very, very hard. We don't have any surge capacity, and that's a problem. Our healthcare workers are exhausted. We have nurses, are gone. More people, healthcare physicians and others are saying we're going to be quitting or retiring over the next several years because we're exhausted. We're not taking this seriously, Bob, and I think our healthcare systems are in the brink.
So as we look, this revisionist thing is very interesting. Is it political? Is it the the kind of libertarian part of our political spectrum that thinks in retrospect that anybody making you do anything is wrong and that's what's going on? Or is it a human natural reaction to want to be done with this damn thing? And part of the psychology of being done with it is somehow forgetting about how bad it was and about the refrigerated morgue. What do you think, Mark? What's actually going on with the revisionist stuff?
I think it's some of both. It is natural for you to block out the pain and remember it differently. But look, in some ways, what worries me more than our healthcare system is our public health system. One might have thought, the average person, I think, could be excused for thinking that something so horrible would bring the country together. And for a while it did, and yet it exposed and in some ways exacerbated political divisions such that now we have people in public health who are walking around with flak jackets with threats on their lives. I worry what happens the next time we have something and a public health leader says, look, this is dangerous, we ought to. So in some ways, we're now primed for people to be skeptics, to be conspiracy theorists, to think that they know better than the CDC, et cetera. So that worries me in some ways even more. And I think that's a serious concern.
Yeah. And Caitlin, I know you've been writing a lot about this and about the attacks on the public health enterprise. You want to talk a little bit about that and what you've experienced personally?
Yeah, I don't know if I'm going to talk about what I experienced personally, but I will say that it wasn't, a lot of us experienced that, especially public facing, Dr. Hotez, Walensky, Fauci, me, I'm sure you, Dr. Wachter. There's a lot of us that experienced death threats and doxing and hacking and stalking. And I mean, you just name it. So much so that many epidemiologists had to move and had to get security details. And it's very scary. It's absolutely very, very scary. And I think it's a serious problem because what will happen is eventually scientists will stop talking in public because it takes such a personal toll. And because of that, I think the rest of the community would suffer. Because they're supposed to also be a part of the conversation, of a healthy conversation. Mm-hmm. And like what Mark was saying, it's the reality of this anti-science movement, but even back to the basics of this panic of cycle and neglect and the underfunded, fragmented public health system that we have in the United States is not getting better. And I would have hoped, a lot of public health people hoped that surely losing more than 1 million people would fix our public health system, but that doesn't seem to be happening. In fact, it's getting clawed back very, very quickly, especially this summer. Mm-hmm. And to me, that is incredibly concerning, concurrent with what Carlos was saying about the healthcare systems.
So I want to get back. We certainly will get back to the kind of revisionism and misinformation and all that kind of stuff. There are a couple of questions that have come in that are kind of more COVID clinical. I want to cover them quickly and then peel back. Maybe first one to you, Caitlin, which is people are wondering how they should. As you mentioned, there is some chance, maybe smallish, but that there will be another surge. Trying to figure out how you follow numbers to figure out that another surge is happening is pretty challenging these days. It's certainly all of my go-to numbers have essentially gone away. Even hospitalization data is now hard to come by. What are you biopsying number-wise to know what the current state of COVID is in your region?
I look at wastewater. San Diego has a fantastic wastewater system. Unfortunately, not everyone has one, but I don't think you need to get that specific to your county, even just your region or state or the region of the United States, just the West, just looking at the trends. And if it starts going up pretty fast, then, you know, start dialing it down. I call it riding the waves throughout the pandemic because, so yeah, I don't pay attention to case numbers anymore. I don't really pay attention to hospitalizations anymore. I really just pay attention to wastewater.
And so let's say it doubled in San Diego. Are you saying that now you would start masking on the airplane and you would perhaps stop indoor dining, that kind of thing? Is it you'd sort of you'd go back to some of the behaviors that you had gone to, let's say 6 or 12 months ago?
I think so. I mean, certainly more masking, certainly a lot more antigen testing after I thought it was a cold, but it wasn't a cold.
Mhm.
I probably wouldn't be trusting negative antigen tests as much as I was trusting positive. So yeah, just a small behaviors, but certainly not enough to pull my kids out of daycare again. Certainly not enough. I guess in San Diego, we're lucky we get to eat outside all the time, everywhere, but I probably wouldn't stop indoor dining either, but I'm at a, you know, different stage and a different risk than a lot of people.
Yeah. How about you, Carlos? If what do you follow, and what would you do, for example, if wastewater doubled or trebled?
You know, I agree with Caitlin. I look at wastewater and I look also at my network, right? I have a lot of people, if I start hearing a lot of people in my network that, oh, I tested positive, or I tested positive, or I tested positive, that tells me there's transmission in my community. And that changes the way I behave. And I get a lot of those calls because frequently people are calling me to ask for Paxlovid prescriptions. So I hear about my network getting positive, and that drives a lot of my decision making sometimes. I also do rely on testing, and if I'm in serious doubt and, you know, 3 tests negative, I'm still having symptoms, I'll get a PCR because, you know, I think I want to be sure that this is not COVID. But I will be I would be more cautious when that case happens. You know, if wastewater surveillance starts going up, if I start seeing a lot of, you know, close contacts having COVID, you know, I will start being more careful. And that's a little bit of what I tell people is a decision, a little bit like thinking about watching the weather and deciding to take the umbrella with you or opening the umbrella or not. You know, it's depending on what it looks like, I'll make a decision whether it's the right time to go without an umbrella or to go with an umbrella with me.
Makes sense. A couple of questions about specific efficacy of a couple of things I want to run by you. You said if you got COVID today, you would immediately start on Paxlovid, both to lower your probability of getting very sick, but also lower the probability of long COVID. A couple of studies have shown that metformin, the diabetes drug, also seems to lower the probability of long COVID. Has that crossed your threshold for a thing that you would do if you got COVID?
I'm incredibly intrigued by the metformin data. I need to look at it more carefully, but yes, I'm very intrigued by it, and I wonder whether it's another approach to be taken, right? Because I'm not ready to recommend it. I'm not ready to do more with it at this point in time, but the data is very intriguing and one that I definitely think about a lot. I also think, though, that there's countries like, for example, Mexico or India that have a lot of people with diabetes, a lot of people in metformin, and they also had a very, very high mortality. So I'm not totally convinced that this is just a metformin effect and something else may be going on.
Mm-hmm. Okay.
And as an ID physician, I like antivirals, you know.
Yeah, I know you have that bias that it's got to be one of your drugs. I want to get back to the revisionism for a second. I think even among people who are clear thinking about how bad it was in 2020, there's a lot of sentiment that we got the schools wrong. And Caitlin, you mentioned I wouldn't take my kids out of preschool. Maybe Caitlin, to start, do you think we got the schools wrong? What did we learn about the schools?
So I was in Texas during the pandemic and as an epidemiologist, and we actually started schools very early. It was August, September of 2020. At the time, I was very uncomfortable as an epidemiologist, but it was pushed forward. And you know, looking back, I think it was the right call. I think that we could have prepared schools and prepared teachers far better with ventilation, with contact tracing, with resources that just weren't utilized in the time of of early 2020. I think the really hard thing that I had in fall of 2020 was that we just didn't have vaccines yet.
Mhm.
It was hard for me to ask teachers to go, even if they're, it's over 65, under 65 is a very random disease before any immunity. And to ask someone to go on the front line, that was a hard decision for me to make before we had any levels of protection for them. And so I don't know.
Yeah, no, it really is a hard one. I scratch my head about it too. But do you think a lesson, as people talk about the schools and we quote got the schools wrong? First of all, it's an interesting question in general. But second of all, if we did get it wrong, was it because we overestimated the risk or we underestimated the downsides of keeping kids out of school, like what the educational attainment downsides were, what the mental health downsides were, what the downsides for parents were, all those sort of things. Sort of which part of it did we get wrong, if we got any of it wrong?
I think that's a really good question. The one thing we got wrong was, well, for one, almost every virus is usually very bad for young kids. And this one just wasn't. It was very weird.
Mhm.
And that is abnormal. So I will say that. The second thing is we thought, and we were wrong, that that schools would accelerate transmission in a community, but rather they just reflected the community transmission. They didn't become these vectors of really high transmission. I was surprised about that.
Why not? You would think they would have been.
I thought they would have been too. I think we
Yeah.
have a lot to learn about that. And was it because of SARS-CoV-2? Was it because it was just literally everywhere anyways? I'm not sure.
Mhm.
I do know, public health people do recognize whole health, the value of mental health, a safety net, meals at schools, and that was very much a part of the conversation in Texas in early 2020 as well. So it's it was a lot of people had to make very hard decisions at that time, and I don't empathize anyone in that decision making effort.
Carlos, first, let's start with, do we get the schools wrong? And if so, what's that lesson learned?
I agree with Caitlin. I think, initially we closed schools. It was a necessary move for a second, but then we kept them closed for way too long, and that has been bad. And in some places kept schools closed forever, right? They basically, I'm hearing now many school districts having trouble getting students to come back. This has been really bad for kids, for parents, and we have to remember that one of the key ways to reactivate the economy was to open schools again. It's very important for parents. You can't go to work if you can't work at home or work period if you have kids around in the house, right? If you have to be the teacher and the mother, you can't do work. You can't be, no matter what happens. So we forgot that. In schools, I work with some schools here in Atlanta. One of them a private school, Paideia School. One of them, the Atlanta public schools, and we did a lot of testing and we kept schools open as much as possible. And yes, we did it before there were vaccines. And once there were vaccines, we prioritized the teachers, and we didn't see outbreaks. We were able to really control transmission and send people, home when they were infected, and really prevent the school from being a site of infection. And that was very important for mental health of the kids. So my message is that one of the things we got wrong is the schools, and we hope we don't make this mistake again when we have another pandemic.
Okay. Let me turn to Mark as I think, only MBA in our group here. One other question, I think there's less certainty when you hear people say it, is we got the balance of the economy and public health wrong. What do you think?
I'm loath to second guess from the safety of the relative safety of 2023, some of the hard decisions that people had to make, like in the schools. In part because let's remember that there was every reason to believe that this virus would be particularly bad for kids. There was every reason to believe that things that turned out not to be so. Remember, we were wiping down our groceries, and we wouldn't touch our face because the virus is, we didn't know. Having said that, it does strike me that the ferocity with which some people opposed what seemed to some reasonable public health restrictions depended in part on whether you made your livelihood, whether you could do your livelihood at home versus wherever else. So last week there was a study published about how likely various occupations were to be working from home. And like software engineers were at the top and butchers were at the bottom. And so if you had saved all your life to start a restaurant and you bought furniture and hired staff and opened your doors in March of 2020, and then it all went to hell, I get how your perspective on the shutdown of the economy and whether or not we, quote, got the balance right would be a little bit different from someone who could set up their Zoom and do what they do as we're doing this now. So you'll remember the early days when it became immediately apparent that certain ethnicities were harder hit, were sicker, were hospitalized more, were dying. And the explanation in the lay press was that they had too many pre-existing conditions, right? And the problems with that were, first, no one said, well, gee, why is it that Black people have more hypertension, diabetes, Latino people? But the second thing was it wasn't entirely true. That the pre-existing condition was that you worked in a meat packing plant, or that you drove the bus, or that you had a multi-generational household. And so the impact of the epidemic and the impact of the restrictions that were imposed to try to control the epidemic under very difficult circumstances hit people quite differently, depending on where you are in the economy. So it's part of why I'm punting on the question, because I think it depends a little bit on where you were, and people were making hard decisions under conditions of great uncertainty. There's no question that aspects of the economy and people's personal lives have been devastated. There's also no question this made the decrease in educational attainment that we're only now beginning to measure may be the longest COVID of all, if you will. It may be the thing that has the most lasting impact on the life chances and opportunities of that generation of kids that went through that shutdown. That's the point.
Yeah.
So Bob, I would say, though, that one important message is, I think in public health, we make the mistake of letting the population say it's either public health or the economy. It's public health versus the economy, when the reality is we need a good public health in order for the economy to be successful. Healthy population is important for the economy to be successful. So we needed to really get the message. And I think in public health, we didn't get the message right of telling people, look, our goal is to get the economy going. This is the public health, and this is how public health is doing it. We're not shutting the economy. We're actually going to do the adjustments to get the economy right. And this, again, it was all about not telling people necessarily what not to do. It was telling people how to do things in order to continue working. And there were ways to do that. And I think we made the mistake of saying no, as opposed to saying, this is what you need to do. And I go back to my roots in HIV. You know, it's harm reduction. It's not about telling people you shouldn't have sex. It's about what to tell them to decrease their risk.
Yeah, that makes sense. Mark, you brought up sort of the issue of health equity and how in some ways we've misinterpreted the higher risk among certain populations. One of the most interesting things, as tragic and interesting things, was sort of the Venn diagram of George Floyd and COVID happening at the same time, you know, as horrible luck would have it. How do you think that Black Lives Matter, George Floyd movement influenced the response to COVID? And also, as you look at, you know, people say, oh, there are these health equity issues, and you could make an argument that they were less profound during COVID than they are for hypertension treatment or diabetes treatment or cancer. So why don't you riff a little bit on what you saw in the health equity world in COVID?
Well, first, let's go back. It wasn't just George Floyd. It was Ahmaud Arbery and Breonna Taylor, and it was a series seemingly every week of one of these incidents that cumulatively, I think, led to people's, the inescapability of this problem in America with police brutality. So I think these things work together. In addition, I think the ground had been prepared largely in healthcare for thousands of articles in the last 20 years that have pointed this out virtually everywhere. And so I think it was difficult for anyone who was paying attention to not understand this already, and therefore be prepared to understand and accept that this, like everything else, was going to affect people differently. Whether or not it leads to lasting change, I think depends in part on what, as a colleague of mine said, which of the things that we've changed in COVID are plastic and which are elastic. Which ones will lead to kind of a permanent change, maybe telemedicine, and which ones will snap back to the way they were before. I note with interest that several states have now banned diversity, equity, and inclusion offices in state government and state universities. Perhaps that should surprise people, perhaps it doesn't, because there's always kind of this tension of backlash around this issue in America. So in some ways, I think the revelation of these problems and the quick succession of a number of incidents accelerated an interest in health equity that was already growing, made it kind of manifest, and gave people an outlet to work on it. How much of that is lasting and permanent remains to be seen.
Okay, I'm going to get back to you later as we talk about technology and telemedicine and all that. Let me just stick with the structural changes and what did change and what's going to snap back. Maybe Carlos, you're probably and Caitlin as well are close to the institutions, the CDC, the NIH, the FDA, all had to react in very different ways than they were used to doing, all received a level of public scrutiny and dealt with misinformation in different ways. What do you think the impact was on those institutions, and are they different? Are they better than they were 3 or 4 years ago? Let's maybe start with Carlos.
Well, I think, first of all, I would say that they're clearly going to be different. I think the public scrutiny has gone up, as you probably saw. Mindy Cohen will be the last CDC director, does not require Senate confirmation. I think Senate confirmation, is clearly raises the level of the agency, but also delays the appointment of a director and makes it a lot more political. It makes it a lot more, scrutinized. I think the way funding is directed is going to change dramatically. We're seeing, for example, at the NIH, how they're putting enormous restrictions on foreign subcontracts as a result of the concern of research funded in Wuhan, China. So I really worry that global health and global collaboration, which is critically important, global trust that is critically important, is going to be impacted significantly by the pandemic in a negative way. I think, what Caitlin said, our public health in our country is a mess, right? It's the way it's run. It's run by the states. You have a federal agency that really has, no authority, doesn't get any data. There's no authority of that agency other than it's a way to collaborate with states. And it's really hard to fight a war with 51 armies going in different directions. And I think that CDC's cloud is going to be, and input is going to be significantly decreased going forward. I think it's going to require a very different CDC view of the world, and a lot of healing needs to happen. As Mark said, when the next pandemic happens and a public health, the CDC director stands up and says, we need to do X, we'll see what happens. I mean, there's going to be a huge backlash, and that's going to require a lot of healing and a lot of understanding. And I think a really leadership to stand behind this person, regardless of whether this is, a Republican or a Democrat. I think what we saw public health become politicized, and public health has always been political, but it has never been partisan. And public health has become partisan. And to me, that is one of the bad things that resulted from this pandemic. Public health has become partisan, and that to me is really terrible. And again, going back to what Mark said, I couldn't agree with him more. We need to understand that structural racism is a major cancer in our society. It kills people. It decreases the ability of people to be productive. And if we don't tackle structural racism, and in a day like today, with that Supreme Court decision, I just feel that we've gone back instead of going forward. So I worry that the gains that we're making in the things that we need to do to address structural racism are not being addressed in our country the way they should be.
Mm-hmm. Let me peel back to the CDC for a second. You can imagine at the end of this, there'd be a 9/11 type commission and say, one of the things we learned is the CDC needs to have more control, has to have data from 50 states. It all has to be transmitted electronically. I remember, getting the letter from the CDC in the beginning, or from the White House actually, saying, fax in your numbers. It was a joke. Any chance that that's going to happen, or is that just the environment is too partisan to ever allow more control by a federal agency?
I would love to see what Caitlin and others have to say, but I think there's no chance that will happen anytime soon. I would love to see that happening, and maybe in a few years. But right now, I think if you try to do that, you will get there'll be a war of Congress between different parties. I mean, you even go to some of the hearings that have been done around COVID. Listen to the last time that our friend Rochelle Walensky had to testify, and I mean, it's like a waterboarding phenomenon. This is not. People are not trying to fix what's wrong. People are trying to blame individuals, and this is totally wrong. And I think I'm not very optimistic of what things are going to happen going forward. We need a leader that really sets us in a different direction, and really we need leadership at both parties that really say we need strong federal agencies to do this, because that's the only way we're going to survive.
Seems unlikely. Caitlin, any thoughts on structural changes of the major organizations?
I have a lot of thoughts, but I'll try to keep them short. I think the overlying theme right now is that it's what Warren Buffett said, that it takes 20 years to build a reputation and 5 minutes to lose it. And I think that's where the CDC is right now. And that there were many reasons for that. Yes, politics was one of them, but they got some things really wrong, just wrong too. And so I'm really paying attention to two things going forward. One is the data infrastructure. I have a really hard time with the debate between, is public health local or is it federal? And in fact, I think it's the perfect balance between both of them, that we need top down as well as bottom up, and that flexibility is needed. There are data modernization things happening right now, which I am very hopeful for, and there's a ton of money going into that, which is needed. Like you said, we were working with faxes and PDFs in the beginning of the pandemic. The challenge, though, is that it's, again, not coordinated on a national level. So you have all these local and state health departments doing very cool things, but all differently. And so the next time it happens, we're going to run into the same exact thing because everyone's on different pages. I think that's a really big frustration right now among public health people. And then the second one, and I could talk about hours for this, is the communication. And this is something that I haven't seen move at all as quickly as it needs to be. The need for scientific communication, the need to be better listeners on a systematic level to address concerns, because there's legitimate concerns out there. And I'm very concerned that we're not training public health scientists, that we're not implementing things, we're not taking mis and disinformation seriously. And that is something that I'm trying to advocate for a lot more.
Yeah, let me just stick with that one for a second. So, you and I have both, as Mark said, thank you, have done a lot of public communication, and this Carlos as well. People have asked me, a lot of people follow you on Twitter. Do you feel good about having changed people's minds? And I say, I don't think I've changed anybody's mind, because the people who follow me are choosing, that's the portal that they like. They like the way I think. Every now and then they decided, when I decided to say, you can be more permissive, they decided all of a sudden I was an idiot, whereas I was very trustworthy when I was saying be careful. It was interesting. More of it came from the left than the right. But everyone now can choose their own information adventure. So it's not obvious to me, how can you argue against better public communication, and you do it supremely well, or scientific communication. But the people that are listening to you and me and Carlos and others are different than the people who are listening to misinformation or purveying misinformation. Do you have any sense how we get at that? It strikes me as, in some ways, the most daunting problem of all.
It is. It's that breaking of the echo chambers, which is going to take a lot of institutional courage on all different levels. But I am actually very proud that the Wiley audience is diverse. I have very, very red people following me, as well as very, very blue people. And so I think that it's possible. And particularly, I think that's the case because I came from the deep South during the pandemic. And so I was listening to a lot of concerns, not just in the community, but my family members that are still not vaccinated against COVID. So it's a very real challenge. But I think that it can be done. It takes time to build trust. There's no reason that someone should all of a sudden listen to Dr. Jetalina because she's an epidemiologist. You have to build those relationships. And I think you need to, even more importantly, sustain those relationships, not during an emergency, during the valleys of emergencies. So when there is a really big emergency, you can activate those networks, and you've already built a relationship with them. And that's something I don't want to see us lose, because a lot of communities worked very, very hard to find those information diffusion networks.
No. Mark,
I think, Bob,
Yeah.
we need to really find their trusted messengers that would work with us. I'll give you an example. I was in South Georgia promoting COVID vaccines once, and I was talking to this group of individuals, and this woman said to me, said, Dr. Del Rio, I'm not going to get a COVID vaccine with, I don't care what Dr. Fauci, Dr. Walensky says, but the moment the fireman sitting next to me in church gets his COVID vaccine, I'll get my COVID vaccine, because that's the healthcare worker I trust. That fireman is a person I see taking people in our community to hospitals and picking them up in the ambulance when they're sick, and I trust that person. So we needed to be working with those trusted messengers to make them part of our group in order for us to be working with them, right?
Yeah, I see your lights. There you go.
I agree. I was just going to say, I agree with you, Carlos. I think one really big network that helped us a lot was community health messengers, community health members and messengers throughout the pandemic. The problem is that they're volunteers, and when we don't need them, we don't engage with them. And if we just engage with them when we need them and not during times we don't need them, but they need us, we're going to get into that whole panic and neglect cycle. And that's something I'm very concerned about going forward.
Mark, I'd be interested in your take on the role of social media and efforts to deal with this misinformation crisis.
Yeah, not an area of my expertise. I agree. It's on the one hand, obviously, when done well, it can be a very powerful instrument for information. It's also a powerful instrument for misinformation and disinformation. I want to say something positive about lessons. Imagine how bad this would have been if it were COVID-09 or COVID-99. Not just mRNA, not just biomedical science, but data science, information science, computer science. We couldn't have this conversation. There would have been no sequencing of the gene, let alone worldwide, more or less instant communication of that sequence, let alone vaccine, let alone the capacity for people to flex, some people to flex to work in other ways. And so one of the positive things of this pandemic, I think, was the way in which the clinicians who ran to the front, who ran towards the trouble, learned on the fly about what worked and didn't work and figured out ways to communicate. The ways in which people who were in charge of public health leadership in where I live in Oakland, the 5 counties, the public health leaders were kind of in lockstep in trying to persuade their communities how to do things. And so there are, I think, some positive lessons to learn and capacities that have been built to be able to flex work to more flexible ways, to be able to communicate more rapidly in the scientific community about both the problem and sometimes the solutions. And so in some ways, it's an awfully good thing that it happened when it did, as opposed to 10 or 20 years ago.
That's a great point. And obviously, we are a play within a play here with, I'm in New Hampshire now. We got Atlanta, we have Oakland, we have San Diego, we have viewers from all over the country, I'm sure, and many from all over the world will watch it later on YouTube. So no question about that. Mark, I want to stick with you for a second. Any changes in the healthcare system? You've been pushing very hard for decades on our healthcare system, not very good, and also too expensive.
Yeah.
Do you think COVID did anything to advance the world of moving toward healthcare value?
Well, first of all, if you were getting paid fee for service, you recognize how fragile fee for service is when service disappears, right? And so all the hospitals are now in the position of saying, hey, remember us, come on back. But also obviously accelerated the trend towards telemedicine that was already happening. Millions of patients and millions of healthcare providers realized tangibly that they were wasting a lot of time and a lot of patients' time and a lot of money doing things in person that we need not do in person. So I think it's opened up new avenues, new challenges as well, but certainly kind of blown apart the notion that healthcare has to happen in bricks and mortar. And so the challenges of measuring quality, which we weren't very good at doing in the ambulatory setting, we now have to go even further and figure out, well, how do you do it in a virtual setting? But I do think that it's shaken everybody about the roles they play. One of the bad things is that it's made people, I think, quite demoralized. You've seen the exit of nurses, largely from the profession, the burnout of physicians, and I hope that it's made everybody focus on how is it that we organize the work of healthcare providers in a way that takes advantage of modern IT and doesn't have us doing stupid, wasteful things, because we need them. We need them to do the things that only they can do, and we need to delegate to machines and patients the things that they can do well, because these shortages are not going to go away overnight. So that's, again, I think some of this is going to be fought out in the policy world, plastic and elastic.
Yeah. We only have a couple of minutes left. Caitlin, Mark, thank you for pivoting from all of us talking about the things we got wrong to some of the things that actually went right and are very hopeful notes for the future. That's, I think, a good way to end. So Caitlin, why don't you and Carlos do the same thing? What do you think of the positives that come out of this? And obviously, as we say that, we have to reflect on the fact we talking about something that killed over 1 million Americans. So obviously, it's anything that's positive has to be tempered as we think about that.
I got to meet all you guys, but
There you go.
Bigger picture, obviously vaccines. I mean, it was incredible to get a vaccine in 9 months. I mean, I wasn't even thinking we would have it in 12 months. And so that was an incredible feat. The other thing, and everything I agree with Mark, and something additional that we particularly saw as epidemiologists was the value and the power of public-private partnerships. I never thought about it being in public health, but working with Google to look at trends, how people were moving and looking at disease transmission that way. Working, CVS and Walgreens with testing and vaccines and distribution. I mean, we can do some pretty darn incredible stuff and pretty innovative when we approached public health with a multidisciplinary viewpoint. And so I thought that was a really cool thing to come out of the pandemic. And I hope it doesn't end, because private can bring a lot of innovation. They can move really fast. They can bring money too. And then there's public health that understands what populations need and want and how to make people healthier. And I think when we marry those two things, the values of us as Americans really shine.
Yeah, let me, as they say in Silicon Valley, double click on that. I thought the data visualization tools that were developed often by groups of volunteers, roommates sitting at home, that would then allow you to figure out how safe or unsafe is it to go to the supermarket today. Some of it was spectacular, and some of it was really the first time a lot of us saw the power of the data, because data in a spreadsheet is not helpful. Data in a form where you can put in what you need and it tells you, gives you an important analysis. It was really pretty magical, and a lot of that came from public-private partnerships. Carlos, I'll give you the last word.
I would say that, concurring with Caitlin and Mark, I think science was amazing. We got science right. Science helped us on sequencing the virus, on developing vaccines, on developing antivirals, on developing rapid testing. We got a lot of things that science did that really science got us out of this pandemic, and we need to celebrate science for what it did for us and how it helped us. Imagine if this has been, 100 years ago, we would be in a very different place, and science made a big difference, and the science we have today made a big difference. But the other thing I would say is that, and I'm going to end by paraphrasing Jonathan Mann, who was the director of the Global AIDS program many years ago. When he was asked what the greatest contribution of healthcare workers and the healthcare public health workforce had been to the HIV pandemic, he said, at a time of plague, we did not flee, we did not hide, we did not separate. And I think all of us in public health and in healthcare, we were there. We went to the hospital. We went to the hospital every day. We took care of people that we were all concerned we could get infected. And yet we were there. We did not flee. We did not hide. We did our work, and we took care of people. We took care of population, and we took care of patients. And for that, I'm incredibly grateful. And I'm incredibly proud of our colleagues having done the way they stepped up at a time of crisis.
Fabulous. I can't think of a better note to end on. So let us do that. Let me thank the three of you, not only for this, but for educating me and our audience over the course of the pandemic, and look forward to staying in touch. And thank you for an amazing work that you've done and you continue to do in lots of different ways. So thank you. Thank you to our audience for being with us. And we will see you back after Labor Day. Have a great summer.